I'm happy to introduce Professor Frederick Sherman, recipient of the first annual American Geriatric Society's Clinician of the Year in 1990, Teacher of the Year by the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai, where he is a clinical professor of geriatrics and palliative medicine and medicine. In 2001, he succeeded Robert N. Butler, MD, founding director of the National Institute on Aging, as a medical editor of geriatrics, an evidence-based clinical journal that addressed the health issues of middle-aged and older adults. In 2008, he received the prestigious Jesse H. Neal National Business Journalism Award, the Pulitzer Prize of Business Journalism, for his editorials in geriatrics. He has been a visiting professor of geriatrics in Canada, India, Taiwan, as well as numerous academic medical centers throughout the United States. In 2009, he assumed the position of Chief Medical Officer for Community and Managed Care Services in ArchCare, formerly known as the Catholic Healthcare System of the Archdiocese of New York. And a little local note, Dr. Sherman is married to Jamaican Pat Rowe, adjunct professor of nursing and founder of the Literacy is a Family Experience life program operating in Jamaica and New York City. The couple share a passion for literacy, and Dr. Sherman will explain why when he makes his presentation. And so I'm very pleased to invite Dr. Fred Sherman to first address you. So please, if you have any questions, you can put them in the chat or make a note to ask after. So let us not interrupt his presentation. Let's make a note, and after the presentation, you may pose your questions, and you'll have about 45 minutes or more to pose your questions. So now I will share his presentation. I have to go right back. I need to stop sharing. I have to go right back. 1 second, please. Okay. Slideshow.
Jean, can they hear me?
Yes, Fred, I'm going right back to the beginning before I share, okay?
I'll start talking to you. Here's the good news. We have about a presentation that'll last about 30 minutes, hopefully, or maybe 45 at the most. Then we can have a good, exciting Q&A. What I'd like to talk to you about today is titled Successful Aging. That's a topic near and dear to me, because we baby boomers, that is those of us who've been born between the ages of 46 and 64, at least the 77 million of us in the United States, and hundreds of thousands, if not millions, in Jamaica, London, and Toronto, we're interested in staying healthy and living longer. Let me have the next slide, Jean. So what the goals of my presentation are to talk about the process of successful aging. Go back one, please. The process of successful aging, and to activate you as middle-aged and older adults to partake in your healthcare in a much more aggressive fashion than we have in the past. I think that the healthcare system has changed. Older adults, middle-aged and older adults generally present to doctors with multiple medical problems, taking multiple medications, and having a host of problems that go beyond the 15-minute visit. And one of my major goals of this presentation is to activate you to act on your own behalf. I also plan to raise some specific healthcare problems and discuss them in a little bit more detail. Although I would encourage, there's a whole host of problems we could talk about. I'm going to talk about some common ones and how they differ in the care, in the management and care of the elderly. And so that's the plan. The next slide, please. Can I have the, Gene, next slide? There we go. Okay. So what are the key components of successful aging? And they're fairly simple. You want to stay free of disability and disease. Now, diseases like stroke and heart attack and peripheral vascular disease and sugar diabetes, in and of themselves don't lead to disability unless they cause problems with function, all right? So, for example, I can't tell you if you presented to me an 82-year-old woman who had high blood pressure, diabetes, and a past history of breast cancer, for example. I can't tell you whether that woman is the former Speaker of the House in the United States Congress or is in a nursing home. I can't tell you that based upon diseases, but I can tell you based upon disability and functional impairment what these people need. And our goal is to try to prevent the disease from progressing and causing functional impairment. And the two major things that you need to have are good brain health and good physical health. All right, so we're going to talk about each of those and how older adults can enhance their brain health, decrease their risk of getting dementia and memory loss, and also continue to improve their muscle mass, their strength, and improve their balance. All right, so the key component here is to have good brain health and good physical capacity. One of the significant mechanisms that gets neglected in terms of increasing both of these things is socialization. That is, staying healthy and living longer means that you have to be involved socially with your peers, with your children, with your grandchildren, with your neighbors. And this often gets omitted, and it's very important. There's mostly women on this presentation, but for us men, you know, who work like women and then retire like women, we haven't built the social networks that we need to build to maintain our social integration, our friendships. And so, in speaking to the men on the call here, I think it's important that you begin to think about the friends you know, the men you know, the women you know, and how you're going to socialize with them to stay healthy and live longer. Can I see the next slide, please? Next. Next slide. Thank you. So go back one, please. Back one, thank you. So one of the basic principles of growing older is that as we grow older, we actually get more different from each other. That's number one. The stereotype is that we actually get more similar as we get older, but actually as we get older physiologically, we get more different from each other. Our muscles get more different, our heart gets more different, our brain gets more different. So two 40-year-olds are pretty similar, but two 80-year-olds are much more different than each other. The other stereotype is that aging begins at the age of 65, which is not true. That the process of senescence actually begins between the ages of 30, 40, 45, and is the longest phase of our life. And it's a myth that everything starts to fall apart at the age of 65. Not true. We also know that each of our organs ages at a different rate than the other organs. So our heart ages at a different rate than our lungs, and et cetera. The overwhelming point about aging in general is that sick old people are sick, not because they're old, but because they're sick, right? So that growing older in and of itself does not lead to, eventually sickness comes up on all of us, but growing older doesn't cause us to be sick, right? And I think we need to appreciate that sick old people are sick, not because they're old, but because they're sick. And that's a very important approach that we physicians have to take and not just ignore the symptoms of that older people have and just say it's old age. The story that Robert Butler, the director of the National Institute on Aging, would tell is that this older man came in to see his doctor and said that his left knee hurt and he had pain in his left knee. And the doctor said, that's old age. That's just old age. And the older man said, well, what about my right knee? That's the same age as my left knee. Why isn't that causing me any pain? So that we have to watch that we don't get pushed aside as just having old age as the excuse for all of our ills, because that's not the case. Next slide. Okay. So the other myth is that older people we have limits to their treatment. In fact, older adults deserve a diagnosis, and that if they have a diagnosis, they deserve a treatment. And I've never cared for an older person or their family for whom I could not do something. So that to be fatalistic and pessimistic about our health in late life is not appropriate, all right? Once again, as I said, old age is not a diagnosis, and older adults are treatable. Next slide, please. So as I said, they deserve a diagnosis and they're treatable. And as I said from the very beginning, treatment is aimed at recovering or improving function, all right? And as I'll say on another slide, management of chronic disease is the critical care of late life. So we treat people to maintain function, to recover their function, to improve their function, and we also cure illness in late life. I mean, while older adults may take longer to recover from an illness like pneumonia or COVID, or from other acute illnesses, even an upper respiratory tract infection or a urinary tract infection, it may take longer for them to recover, but they will recover. So we not only care for older adults, we also can cure older adults. And that's the mentality that we have to have. Otherwise, it's too easy to say they're just that we all, and I'm 77, that we're all just older adults and it's old age. Next slide, please. Also, you know, I think older adults present with illness differently than do middle-aged adults. So I'll show you some examples of that. So you shouldn't, you know, how you presented to your doctor at the age of 50 will not be how you present to your doctor at the age of 80. At the age of 80, you'll probably have functional impairments that may be caused by specific illnesses, whereas at the age of 50, you'll generally present yourself with that specific illness. So a fall or a change in your thinking or some unusual symptom may be the cause of an illness in the 80-year-old, but in the 50-year-old, it'll be very specific. That's why I actually got into taking care of older adults, because taking care of 50-year-olds is pretty easy, actually. Taking care of older adults is a much more complex task. It's almost, in some cases, it's like solving a mystery. So let's go to the next slide, please. I think that just says what I said. You're different and you should be treated differently. That's part of your activism and getting you activated. So as I said, older adults could present atypically with different presentations. So serious infection can occur without a fever. Weakness can be the only symptom of a heart attack. Confusion occurs commonly in older adults when it can be caused by a whole bunch of different things, from simple things like heart attack, like fever, like urinary tract infections. Stroke can present with an irregular heartbeat, and falling can be caused by multiple frailties, not just that you tripped over a sidewalk, an elevated sidewalk, or a hole in the sidewalk. There's multiple factors that can cause this. So to activate you as mature and older adults, you need to let your doctor know all about your symptoms, and don't attribute it in your mind or give them the advantage of thinking it's just old age. And don't tolerate the response that it's just old age. That's very important. And also, I think it's important when you go to, you may, in the heat of the evaluation and the doctor coming and the technicians coming or whoever's going to see you there, you may forget I would definitely write a list down of the 3-4 things that you're concerned about. Because often we older adults, when we go to the doctor, it's not just one thing. There's 3 or 4 things that are on our mind. And if you need to negotiate those 3 or 4 things with your doctor, I'm giving you the permission to do that, all right? Once again, when doctors see a 25-year-old or 30, can be a specific issue that can be addressed. Their chief complaints are multiple, all right? And don't be short shrifted when you see your doctor. Next slide. Next one.
Can you hear me? Can we hear me, doctor?
Yeah, I can hear you very well. Can you hear me?
There was a bit of a break, but I can hear you now.
Okay, good. So this slide merely shows that the same thing about it, things can present in unusual ways in older adults. All right. So if you look at the symptoms of in 50-year-olds on your left, and you compare them with patients 75 and older on the right, the chest pain, they may be decreased in intensity in somebody, in an older adult having a heart attack. They may not be sweating. They may not be breathless. They may lose consciousness, which would be atypical in a younger individual. They're more likely to have a stroke, and they're more likely to present confused. So that your doctor has to be tuned into the fact that you're different. You're different because you're older, and they have to understand that you're not going to be presenting with illness just like out of the textbook that they study. They have to study some geriatrics. They have to learn about the care of the elderly. Something I've spent my entire career trying to do. Next slide. Next slide. So this is an example of this is a scan of the cross section of the middle of the thigh of 2 adults, and the red part is fat, and the yellow part is muscle, and the white part is bone, and both how much more muscle mass, how much more yellow muscle the individual, the 90-year-old in the bottom half of the slide has, compared to the woman on the top, compared to her muscle mass. The woman on the top is wheelchair bound, doesn't walk. Right? The woman on the bottom is a healthy 90-year-old who's stair climbing and who's doing some exercises to try to prevent the muscle mass loss that occurs with normal aging and also with our sedentary lifestyle. So there's simple things that you can do to improve your muscle mass so that you're less likely to fall. It's easier for you to go up steps. You're less breathless when you walk. A whole bunch of things to improve your muscle mass. And I'm not talking about bulking up. I'm not talking about looking like Arnold Schwarzenegger. I'm talking about just improving your muscle strength and your muscle mass. Because with normal aging, there's this phenomenon called sarcopenia, S-A-R-C-O-P-E-N-I-A, which is normal muscle mass loss. And that occurs about 1% per year past the age of 30 or 40, and is worsened by sitting around and being sedentary. And in fact, the adults, the older adults who begin to try to improve their muscle mass, the ones who are most successful, that is increased it the most, are those the ones who start from being most sedentary. So it's just the opposite of what you'd think. You'd think that the ones who are most sedentary have the least to gain by improving their muscle mass, but they actually have the most. They gain the most once they start exercise training and lifting small amounts of weight. Next slide, please. Next slide, please. So there's simple things you can do. You can buy go back one, please. You can buy ankle weights. Go back one, please. You can buy a set of ankle weights, and I recommend a 20-pound ankle weight to get, and you can take out 15 pounds. You can put that on your ankle, and use it on, start on your right ankle, do 3 sets of 8 repetitions, Monday, Wednesday, and Friday, starting with 5 pounds. I've never met an older woman or older man who walked into my office who couldn't lift 5 pounds of ankle weight, all right, to start with. Now, the iron that you're pumping should be progressively increased. If you just continue to do 3 pounds or 4 pounds or 5 pounds, you're not going to stress the muscle enough to increase the muscle mass and thereby increase the muscle strength and lead to prevention of falls, lead to increased ability to get out of a chair with ease, go up steps, a whole bunch of things. So, and you need to do this on a regular basis. As I suggested, Monday, Wednesday, and Friday, start with 5 pounds and build up. You can also have somebody make a bucket of sand and start with that. You can have bags of sand. There's all kinds of ways to do this. These are just ankle weights that I've used both professionally and recommended to patients as well as personally. Next slide. So, as I said, the regimen would be, and this is a physical therapist demonstrating ankle weights on an elderly woman. It has to be progressive. You need to increase the weight. Just don't lift 3 pounds or 5 pounds the rest of your life. Increase the weight. That'll increase the muscle mass. There's very few side effects from this. Even if you do have minimal or moderate osteoarthritis, actually that would help build up the muscles around the knee, and is actually one of the approaches to decreasing the pain from osteoarthritis. So over a period of 8 weeks, look what happened here. The strength gain doubled. The mid-thigh muscle area increased about 9%, which is nothing visible. The walking speed increased by 50%. That's all the good news. The bad news is, and these are 90-year-old people, that after 4 weeks, if you stop it for 4 weeks, you're going to lose about a third of the maximum strength that you generated by doing it for 8 weeks. So you need to keep it up. All right. Many of these things that I'm going to recommend are chronic things that you need to do. All right. And the problem with implementing chronic lifelong things like exercise, diet, etc., is that it's like making New Year's resolutions. We lose our enthusiasm. But I'm telling you that successful aging is dependent upon chronic disease management and chronic interventions that you need to do for the rest of your life as an older adult. Next slide, please. The other, so in terms of falls, which I've talked about briefly, there are just the exercises I mentioned, decreasing strength leads to decreased risk of falls. Also, Tai Chi has been very successful in reducing falls as well. So that's an exercise that can be performed with groups or by yourself. Next slide, please. Or you can perform balance exercises alone. And incidentally, there's videos in both. You're going to get a set of the slides, I believe. There's exercise videos of using chairs to improve chair exercises to improve balance. So if you can't get out of the house, you can do certain chair exercises that are recommended on the video that's associated with this particular slide at the bottom. And you can do this with your weights as well. So you can start raising 1 foot. You can use the ankle weight starting at 5 pounds, for example, or 3 pounds. You can do one knee to the next knee. Do it slowly and 3 sets of 8 repetitions. Monday, Wednesday, and Friday is the way to go. Chronic exercising improves balance. Next slide. It's loon. So here's the reductions in falls risk with the various types of exercise. So any type of exercise is a 10% reduction. And this is over a period of 10 to 36 weeks. If you do balance exercises, you do almost a 20% reduction. And if you participate in Tai Chi, you almost have a 50% reduction. So you have a mechanism in which to decrease falls, all right, which occurs in a significant number of older adults. I mean, for example, the president, our 80-year-old president of the United States, President Biden, who gave his State of the Union message the other night, he's fallen a number of times, and He's fallen off a bike. He slipped going up the ramp to Air Force One. And if I were his doctor, I would be recommending a whole bunch of balance muscle strengthening exercises for him to use so that he can continue to be our president and stay healthy. Next slide, please. So what's wrong with this guy? Here's an older man who's vacuuming his home, his kitchen, it looks like, living room combination. So, you know, what are the risk factors he has for falling here? Because, you know, you could go around your own home and see there's a whole list of things on the web about fall prevention and changing your environment in your own home. So, you know, he has a throw rug. He's vacuuming a throw rug. He should get rid of the throw rug because he could slip on that rug. That's number one. Number two is the vacuum cleaner hose is wrapped around his leg and he could trip over it. My mother, at the age of 90, tripped over the electric cord that she was using in her vacuum cleaner, despite the fact that I had asked her to buy a vacuum cleaner without an electric cord and even volunteered to get her one, but she refused. She did fall and tripped over the cord and actually fractured her hip. So this gentleman's at risk to do that. He's wearing clogs, which look like they have an open heel in the back, which is not the best and most secure footwear to wear when you're doing anything for an older adult. He's also probably wearing bifocals or some kind of multifocal lens in his glasses, which is also a risk factor for falling. And then finally, as you can see from the floor, it's shiny in certain areas and can be deceptive and can make it look like there's water spilled on the floor. So he needs non-glare wax to prevent this glare that's on this photo. So there's a whole bunch of environmental things that you should do in your own home. You can go to the National Institute of Aging website and they'll give you a list of things that you should do. You should walk around your house, look for cords, look for rugs, look for things that you could trip over to prevent falls. Next slide, please. So this is a statement I made before. The management of your chronic diseases is a critical care of late life. I think that as I said, we can treat acute illness in older adults. Older adults have less reserve to recover from acute illness, but they can recover from acute illness. It may take longer for them to recover because they have less organ reserve, which is one of the hallmarks of aging. So, for example, if you had pneumonia, as I mentioned before, older adult who has pneumonia to resolve to resolve on X-ray than it does in a middle-aged and younger individual. So it just takes longer to recover, and recover may not be totally back to normal, but it may be close. All right. So I think in terms of the management of chronic illness, that just because you feel better, just because you feel better or have no symptoms, you should not stop taking your medicines, not stop your diet, not stop your exercise, not stop your preventive health screens, and not stop your vaccinations. You need to continue to do this. It's an ongoing, lifelong relationship with your health. One of the biggest problems is non-adherence to medications. Next slide, please. Oops. I got another example of a common illness and what's different about it in the elderly. So typically in middle-aged and young, it's diabetes, and typically in middle-aged and younger individuals, the ABCs, the American Diabetes Association came up with the ABCs: aspirin, hemoglobin A1C, control your blood pressure, control your cholesterol, and stop smoking. All right, that's straightforward healthcare in younger and to a lesser extent middle-aged adults. But older adults require a whole different and expanded approach. All right. Because we know that diabetes is associated with memory loss and thinking impairment in some individuals. There's a higher risk of depression. There's drug-drug interactions that occur with diabetes because of multiple drugs that they're on. There's problems with eye care that can increase risk of falling. There's difficulties with exercise, maybe difficulties with exercise and certain adaptations that need to be done for the elderly diabetic. Elderly diabetics need foot care. They have an increased risk of falling, and they sure as heck should get their flu and pneumonia vaccines. And then older adults who have diabetes are susceptible to what we call the geriatric giants, which are falls, increased changes in memory and thinking, multiple drugs, and other kinds of disabilities. And then finally, the older adult with diabetes may need specialty care. They may need photocoagulation for their the eye complications. They need certain medicines for the neuropathic complications of diabetes. So that, once again, what I'm trying to tell you is that the care of the older adult is more complicated, complex, and it's not just straightforward. So you need to come with your questions, come with your lists, and make sure that your doctor's aware of that. Next slide, please. Okay, so I've talked a little bit about mental function and cognitive function. And I think what's important to think about is that Alzheimer's disease and other forms of dementia increase as we get older. Excuse me. So the issues are, what is it we can do to prevent complication of developing memory loss and thinking disorders in older adults? Having a little problem coughing. Hold on, just hold on 1 second, please.
Sure, no problem at all, because this chart is very interesting. We can go on watching the chart, looking at the chart while Doc gets his water.
I'm back.
Okay, I was just saying that this chart is so interesting that you can really take a break while they look at it carefully.
Good. So these are the risk factors associated with developing dementia in late life. And these are things that you can do to prevent it. So, and what's interesting is...
Sorry, Doc, is your camera off?
I think so. Oh yeah, here we go. Unable to start video. I don't know why it got off. We'll go back on. Can you hear me? Okay, so here are things that we can do in early life, middle age, and old age to prevent memory loss and dementia. And what's most striking is hearing loss. That is, that hearing loss accounts for 8%, which is the highest risk factor for developing dementia, 8%. So we need to pay attention to our hearing as we grow older. I actually have 2 hearing aids that I'm wearing right now. That has improved my hearing, actually, and allows me to focus and not lose any words that people have said. And the other thing that's very important, besides controlling blood pressure, cutting down on alcohol use, not smoking, social isolation, air pollution, and diabetes, all of which are other factors, that ironically enough, having less education, which is something that my wife and I are committed to, both in Jamaica and in New York City, amongst pre-K, K, basic school, and infant departments and primary schools, to improve literacy, is the second highest risk factor for developing dementia. So in late life. So in early life, we need to improve education, improve literacy to prevent dementia in late life. And similarly, we need to address hearing loss. So that the good news about hearing loss is that if there's recent introduction, as the president said, of low-cost hearing aids, of non-prescription hearing aids that are less expensive and for mild to moderate hearing loss can be very beneficial. And we know that getting hearing aids, and I'm not advertising for them, but getting hearing aids actually decreases the risk of memory loss. There's more and more data on that. So I'm encouraging any of you who have hearing loss or are aware of it to get tested to see whether you would benefit from amplification and from 1 or 2 hearing aids. Very important. Next slide, please. As I've mentioned, chronic problems deserve chronic treatments. There's two diets that I want to address that have implications for all of us, and have to be modified, but from whatever country we come from and whatever the dietary patterns are. But the DASH diet, which is a diet that's been proven to decrease high blood pressure and lower cholesterol, emphasizes vegetables, fruits, grains, fish, poultry, beans, nuts, seeds, and vegetable oils, particularly to a certain extent olive oil, and limits the items on the right-hand side. Once again, this is a no-brainer, but it takes control to stay away from all those things. The best thing to do is not to bring any of the items on the right in the house, or as few as possible. So the DASH diet is one diet that's been proven to be effective, lowering blood pressure. Next slide, please. And the Mediterranean diet, which is a diet that was developed in multiple countries around the Mediterranean, has similar items in it. The difference is that it emphasizes extra virgin olive oil. And in fact, in the studies that were done, they actually gave, I think, a quart of olive oil to every family that on a weekly basis when they tested the validity of these diets. So the good news is lots of vegetables and whole grains, lots of olive oil, moderate amounts of fish, cheese, yogurt. You can have wine, but the recommendations are not to start drinking wine if you haven't drunk it in late life, haven't drunk it earlier, and to stay away from meats and sweets. No surprises, but sometimes difficult to do. But this is the kind of chronic disease management that you need to undertake to stay healthy and live longer. Next slide. So medication adherence is a big issue in the elderly. Depending upon what country you live in, frail older people can take up to 9 or 10 different medications. If you don't take the medicines, they're not going to work. One of our Surgeon Generals said that in the past. So you can use various devices to improve adherence to your medications. Most medications, many medications are generic, the cheaper generics, and I recommend them because cost is always an issue. And if you have to spend a lot of money, you may not want to buy them, and you may not take them in the doses that are recommended. Next slide, please. So poor adherence, that is, cutting down on your medications, can come from you have a side effect and you stop the medicine. Well, you need to discuss that with your physician, and maybe they started at too high of a dose. In the older adult population, we generally start low and we gradually increase the medicine. Start low, go slow, but be prepared to go high with the dose. But it's often the side effects that turn people off, all right? There also may be lack of understanding about the benefits. I mean, for example, controlling your blood sugar or your hemoglobin A1C, depending upon your other problems that you have and depending upon your age, you may not feel any different. With the control of your blood pressure, you may not notice that your blood pressure is now less than 130/80 when it had been 160. Incidentally, when we first started to look at high blood pressure in the elderly, we thought, well, maybe it was okay to have the higher number, what's called the systolic, was your age plus 100. So I'm 77. So if I went to my doctor in the good old days in England, they would tell me it's okay to have a blood pressure of 177/90. Well, we now know that that's not true. That leaving me with 177/90 is not a good idea. It increases my risk of stroke, heart attack, congestive heart failure, and death. We now know that treating that blood pressure down to 130/80 is the way to go. And in some older adults who can handle it, we even go down to 120. You need to understand that the benefits of getting the blood pressure down may be silent. You may not feel anything. So you say, okay, my blood pressure is now 120 or 130/80. I'm going to stop my medicine. That's not the way to go. If you stop your medicine, your blood pressure is going to go back up. There also may be drug-drug interactions between the multiple drugs you're taking. You can go on the web and find an app that'll tell you about that. Cost, as I mentioned, is an issue. And then inaccessibility. You want to make sure you get your medicines in non-child resistant containers. In the United States, that's an easy issue. You just need to tell your pharmacist you want it in the easy to open tops. Or you can tell the doctor can write that on the prescription. The pharmacist can volunteer to ask you whether you want it that way, but you can get them into easy to open tops. Even through mail order, you can get it through easy to open tops. Next slide, please. So you need to inform your doctor of any medication side effects and other reasons that you decided not to take your medicines. If you think other approaches besides, approved drugs are the way to go, that is that you want to use garlic or you want to use other kinds of herbs and stuff, I think you should discuss that with your doctor so that you can be informed of whether any of these items, these herbal medicines, have side effects and whether they've actually been shown to be efficacious. Because you may be substituting a non-effective drug, a non-effective, herbal medication for an effective drug. And that will only lead to harm, and you may do fine until you do develop a stroke, for example, or a heart attack. Next slide. So I've talked about in the beginning about socialization and that you want to defeat loneliness. And that's been a major issue. And we've known that socialization is a very positive, has a very positive effect on your health. I noticed that personally myself, that, I need to actively pursue friends and relatives and colleagues and interact with them and laugh with them and enjoy them and have them enjoy me. In fact, as I always say to my friends, if you think of me, call me. And it takes a little time. And we men, as I said in the beginning, are in the back seat on this. I think women really do a much better job of socialization than we men do. And I think it shows up as we grow older, that women have groups, women talk to other women. Men need to do that. Men need to do that. And I've listed a whole bunch of things you can do. You can go on the web. You can just think of many of these things are perfectly obvious, but you need to pursue them. You need to actively pursue them as part of your life. If you just stay home and watch TV or you go on social media, it's not a substitute for this kind of interaction. Next slide, please. And these are just more ideas and things. For example, even joining this group is an example of socialization that benefits everybody who's on this call. All right, it's very important you continue to do these things. Next slide. So, it's interesting if you look at the people that are involved in healthcare as we grow older, and you look at what the derivation is of their work. What is the word that they use to describe themselves derived from? And here they are. What's interesting about this, I found, is that the word doctor actually comes from the word docere, which doesn't mean to care. It doesn't mean to cure. It means to teach. It means to teach. And I've never met a group of older adults that I could not teach something to. And similarly, I could never met a group of older adults who could not teach me something. So that teaching, particularly about problems and the solutions to the care of older adults, is very important. And the more that you can learn about it, the better off you'll be. Your doctor is one resource, and all of these other people are also resources as well. They have varying degrees of knowledge about the care of the elderly. But certainly the nurses and the social workers who work with older adults are going to have an increased knowledge of how to help you. Next slide, please. So as I've said before, you need to communicate with your doctor. This is part of my activation speech. You need to have your doctor teach you about your health problems. And you need to find doctors who are knowledgeable about the care of the elderly, or they're going to get knowledgeable and they're going to be able to explain it to you. You're not a 15-minute visit, and you need to come with your list of problems. I want to activate you, right? If you don't do that, you're going to get short shrifted. Next slide. So as I want to conclude here with, if you take care of older adults, they're on making order out of the complicated presentations they have, the atypical presentations, the multiple illnesses, the multiple drugs and treatments, and any functional decline associated with diseases. This makes, in my opinion, geriatrics and the care of older adults fascinating and very interesting. It's just not straightforward medicine. It's complicated, and I enjoy these complications. Next slide, please. That I've already told you already. Make sure your doctor knows your wishes. If you have complicated and complex problems, which you may, then you should try to seek out those doctors who can help you with the latest research on it and find healthcare that caters to your condition and needs. You may need a specialist, and you need to find the specialist who knows the most about the care of your particular disease in older adults. And actually, many doctors, as they've aged and their patients have aged, end up taking care of a whole lot of older adults. And they think just because they take care of them that they know how to do it. They really need to study it and think about it and read about it, all right? And you'll get a sense of that as you grow older with your physician, whether your physician is learning more about the care of the elderly. Next slide, please. Finally, it takes a team, and that team can, sometimes older adults need what I call therapeutic advocates. These are family or friends who may advocate for the older adult who can't advocate for themselves. If you have relatives who have memory loss and thinking problems, they may not be able to advocate for themselves. So you, as a healthy older adult, may have to advocate for your family member. And I call this therapeutic advocacy, and it's very important. It's very important because all of the things that I've credited you with, you may need to bring to bear on your sister, with your mother or father who's involved with the healthcare system, but really literally can't speak for themselves, can't express themselves about what they need. So it takes a team, and you shouldn't be shy about this. You should not be shy about this. I've had to do this with my mother and with multiple relatives where I've had to step forward and advocate for them. It's easier for me as a doctor, but family members and friends need to do it for their older adult friends and relatives. Next slide, please. Finally, this is what happens if you don't advocate for your patient and you don't address their needs. Patient pulls on your stethoscope and makes you pay attention. So that's what I've advocated for you to do. Pay attention to your own needs and complain to your doctors and make sure they pay attention to you. Thank you.
Thank you so much, Dr. Sherman. I mean, this really gives us a lot of practical advice on how we can age successfully. And I think we have a few questions. Who has those questions? You want to stop sharing? Yes, let me stop sharing. Yes, well, just pass it to me if you wrote them down, or should I just open the chat? Okay, so, all right, so here is a question, Doc. What is the best treatment for plantar fasciitis?
Okay, so the best treatment for plantar fasciitis, which is an inflammation of the ligaments and the cords that go in the middle of the foot. I mean, there's a whole bunch of things that can cause foot pain, and plantar fasciitis is the most common one that's talked about. And the major treatment for that is pressure relief. So you need to get inserts into your shoes that you can buy over the counter and put them in your shoes. You can take an anti-inflammatory medication like Advil or Motrin, and those are basically the two things that you should start with. If you want to go high, if those don't work, you can get shoes that are put less pressure on the middle part of your foot. The other foot pain. So those are the three things you can do. the other foot pain issue that comes about is called a metatarsalgia, which actually occurs in the front part of the foot, just behind the toes. And I actually had that. I had it for 6 months. Every step I took was painful on my right foot, every step. And I needed to do all of the things I mentioned for plantar fasciitis, in addition to getting a specific pair of shoes that was over the counter. It wasn't prescribed. That within about a month relieved my pain. If none of those things work, then I suggest you see your doctor, see your podiatrist, search the net. What's the next question?
Next question. Charmaine, put it on the screen for me now. You didn't. Okay, there's a question here. Oh, Charmaine, can you put back up that slide for me?
Oh, this one.
The
okay.
one, yes, the questions.
Oh, I haven't typed all of them.
Just type that one for me. Just put up that one now for me. The second one. Okay, next one, right. How do you deal with someone who tends to drink sweet things? Meaning my mother will use sugar and milk in her tea.
Well, there's all the rage to cut out sugar from and decrease sugar. If your mother is, so what's the result of this? Is your mother overweight? Does your mother have diabetes? Does your mother have any complication from doing this?
Charmaine, does your mom have any? You can open your mic and unmute and tell us. Are there any complications from her enjoying her tea with sugar? Can Charmaine answer? I'm not hearing her, but
Oh, sorry. No,
yes.
there's no, the doctor told her that she is pre-diabetic, and so she has to cut down on that. So, we try to limit the amount of sugar I will put sugar in the bottle, but then by the end of the week, it's almost finished.
Mhm.
And she's possibly the only person that drinks sugar in the house.
Yeah.
And if milk is there, she'll put in the sugar and she'll put in the milk. And I would say, why are you putting so much in your tea? You don't need both of them. But then as you turn your back, she goes and she does it anyway.
So is she overweight?
No, she's not.
Oh,
She's not.
okay. How old is she?
85.
I would let her enjoy her sugar.
Okay.
That's what I would do.
Okay. All right. Thank you.
She's 80. I mean, listen, if she at 80, 85, the pre-diabetes is not going to do anything for her. The chance of her becoming diabetic are relatively small over a period of probably 10 to 12 years. So hopefully she'll be around for that long. I would let her enjoy her sugar and enjoy her milk.
Okay.
I wouldn't make a big deal out of this. It's gonna throw a line between you and your mother and become something that you're constantly aggravating her about.
That's
And,
true.
I
That is true.
I would socialize with my mother and enjoy her.
Okay.
Good.
Great. Someone is asking, are aqua aerobics effective exercise?
Yes, actually, they are. I don't know if anybody studied them for balance, but resistance. But aqua aerobics are resistance exercises done in the pool. So you have special equipment that gives you more resistance, or you can probably do it without that special equipment. But the more special equipment you wear, the more resistance you could get. It's good for your muscles. The resistance will build up muscle mass and prevent muscle loss. A stationary bike, which I have, and is an excellent in-house, easy to use device to get aerobic exercise. I have an old Schwinn bike. In the United States, sometimes you drive by houses and you see people selling them for $25 or $35. I would stop and buy them at the drop of a hat because they never rust, they never wear out, and you can always buff them up and get new pads for them. And the good news about these Schwinn bikes are they give you resistance going forward and backwards. So you can pedal forwards 2 minutes, 2.5 minutes, and backwards 2.5 minutes, and you use different groups of muscles. Most of the stationary exercise bikes, you only get resistance going forward, all right?
Yeah.
So this Schwinn, and to be honest with you, I go through period, I've had it now for probably 40 years, maybe even 50 years. I go through phases where I'm on it, 2 or 3 times a week, and then I go through phases where I hang clothes on it. I'm telling you the truth. So I'm just as bad as everybody. I'm saying can't keep up a chronic health habit. So it's hard. It's hard, but you can do it. And so a stationary exercise bike, in Jamaica, it may not be an issue, but in the United States, where we have winter, we used to have bad winters. Now we don't have such bad winters, but we have bad winters, etc. I couldn't go out and exercise. So and I used to run, but I can't. I don't run now. But my stationary exercise bike has been a consistent source, an episodic but consistent source of exercise for me for 40 to 50 years.
Great.
No rust.
Yes. Well, there's a question here. I guess it's one for CCRP. I work out and my mother is at home in the days. How can I find somewhere that she could possibly go in the days to be able to socialize? And would you believe, just today, we got an email from a lady who is a nurse, a retired nurse, and she wants to get involved in something like that. We're actually setting up a meeting with the National Council of Senior Citizens and Mona Wellness, because they have good space, to see how we can have activities where you can take mom there, she can play games, she can do some light exercise while you go out. So we are indeed working on that. Our meeting is tentatively scheduled for March 15th. So by the end of March, we should be able to tell you something more about that, Charmaine. All right.
Okay, thank you.
You're welcome. I'm just going down with other questions. I don't know if there are any hands raised. All right. It says here, I started on a whole foods plant-based diet 4 years ago, and I was able to reverse my A1C, cholesterol, and BP meds. I also play Tai Chi. Sorry, I can't see the chat that I was just reading from. I also play Tai Chi 4 times per week and do other exercises. Thanks again. This was really informative. And this one says, why is it?
Wait a minute, before you go on, we should give that lady a clap. She's actually doing and continuing to do everything I talked about. But
Well done, Connie. Big applause for you.
I mean, really, she's done a great job. She can give a talk next year.
Okay, so why is it a patient has to take some lifestyle disease medication for life, even when the condition improves, e.g. high blood pressure?
Okay, well, if the blood pressure will improve on the medicine, it'll go down. I pretty much guarantee that. It may take multiple medications to get it down, but we'll get it down. That's number one. The only way so the issue is, and the person's asking, well, do we need to take medicine for the rest of our life to control the blood pressure if we change certain things? So if you lost significant amounts of weight, for example, or if you and you changed your diet and started to eliminate salt from your food, and I'm not talking about salt from the salt shaker from the table, because that contributes a relatively small amount of salt to our diet. What contributes a lot of salt to our diet is canned foods and salt in other foods rather than salt from the salt shaker. Or just as another item, you can use salt substitutes, which in a recent study have been shown to decrease blood pressure just a tad. So that's another thing you can do. But the point is, you have to modify some other risk factor. You have to either lose significant weight, change your salt intake to lower your blood pressure, and then you can decrease your medicine and see if your blood pressure stays low. But that's what you need to do.
As Connie did. Yes.
It generally takes for blood pressure management to have an effect. It generally takes somewhere between 12 to 24 months of taking the medicine before it starts to have a beneficial effect. It may actually even take, well, actually, the recent trial, the sprint trial, was stopped at 3 years. So let's use 2 to 3 years. So you got to take it for at least 2 to 3 years to see the benefit and decreased risk of stroke and heart attack. So the time, what's called the time to benefit, is something you need to enjoy and do. And once it's down, your blood pressure is down, then you can see if you've lost, whether you've stayed on the DASH diet, like this woman has said, changed to a plant-based diet. What do they say about this plant-based food? They say, eat it if it comes from a plant, don't if it's made in a plant.
You
So,
know, that's
so
like in a cat.
yeah,
That's a good one. Certainly.
that's a Jamaican saying.
Yeah.
Connie has her hand up. Connie, go right ahead, please.
Hi, good evening. I just wanted to say that my story is that I am 73 this year. And I went to my doctor and she told me, oh, your blood pressure was high, including the A1C and the cholesterol. So yeah. I had heard about these doctors in Newfoundland that was able to use diet to reverse the symptoms of these illnesses. So that's where I started, and I did their online courses. I did some of their in-person courses, and I immediately just changed my lifestyle. It took me about 3 months. I measured the numbers right away before I started, and it took me about 3 months to reverse the A1C, and that includes eliminating all oils and all processed foods, and dairy, of course, and meats and everything else. And then within 9 months, I reversed the cholesterol. And within 2 years, as the doctor just said, I reversed the 20-year blood pressure tablets that I was on. But it is difficult to do it. It's you know, it's not eating today, you know, good, and then tomorrow revert. I just had to stick with it for it to work.
So what's special about you that you were able to do this?
I just didn't want to be on tablets. I lived in North America, you know, for the last 50 years of my life. And I was just getting too many issues were coming up for me, allergies and arthritis and now all of the blood pressure, cholesterol and everything else. So I decided, you know what, my health is more important. And because my mom lived until she was 103, I felt, and she didn't have a pain in her lifetime, even though she lived in North America for 25 years, but she was able to, she had good, I would say plant-based Jamaican food in her earlier years. She came to North America when she was like 65. So I figure if she was able to do that and live till 103 without pain, then I definitely didn't want to go down the pain route. So I decided, you know, my health is more important to me.
So let me just comment on this. Congratulations. I think that's really wonderful what you did. Let me ask you a question you may or may not want to answer. Did you lose weight?
I did. I didn't set out to lose weight. To tell you the truth, I thought at 150 pounds I was okay. I didn't initially want to lose weight, but just by switching diet, yes, I'm down to 129, 130, in and around there.
Right. So you're right. The issue is the timeline. So you could have taken pills between to lower your blood pressure pretty quickly within weeks to a month or two. And
well,
then,
I was on
let me finish my thought. And then done what you did, which is change your diet and then gradually reduce the pills as you lost the weight and control and went to a plant-based diet. You could have done that. The benefit of that approach would be you would have you would have decreased your risk factors almost immediately.
Mhm.
Had the benefit of that while you took this longer journey to change to a healthier diet, etc.
I was working, the minute I went to Ministry of Health, I developed high blood pressure and I couldn't quit to take care of my health. So I took the tablet, but I was on the tablet for 20 years.
Yeah.
So when I got the opportunity now or the understanding and the knowledge of how to do this, then I opted for that route. So I
want to say something about your mother. She died, how old was she when she died?
103.
Okay, so let's talk about your 103-year-old mother. That's pretty old.
Mhm.
The oldest patient I thought I had in my office at one point was 112. This was a woman who came up from Alabama in the southern part of the United States and moved to New York City with her relatives. And I remember very vividly, this was probably 25 years ago. It was a Thursday night because that was the night I had night hours. And in comes this older woman, and she comes with a scrapbook of all of her birthdays, you know, down in Alabama, of 100, 101, 102, all the way up to 112. So I thought to myself, here I am on Long Island with a 112-year-old woman. This is epic. I mean, this is extremely unusual. I may be seated with one of the few women this old, you know, ever. So I asked, the problem was I asked the question that just blew everything up. I said, can you show me your birth certificate? Do you have a birth certificate? You know, and she doesn't have it, but she did have the scrapbook that went from 100 to 112. But about your mother, it's interesting because, you know, the issue is genetics versus environment, and that's the big issue. We know that with younger people and middle-aged people, that genetics plays a much greater risk in terms of illness than does environment. But as you get older, genetics plays much less of a risk, less risk, and environment plays a much greater risk. So, you know, it's said that, you know, if you have long-lived parents, you'll live long, all right? Well, that's maybe in part true. But if you don't deal with the environment, if you don't do what Charmaine did, if you don't control your diet, if you don't control your weight, if you don't control your blood pressure, that's the environment, then you're going to run into problems. So in a sense, Charmaine, you've been blessed. You've been blessed by a long-lived mother, and you've been blessed by the fact that you have taken the environment into your hands and changed it. So congratulations to you.
Yes, congratulations. I see a question here. When is blood pressure considered too low, and what is the best treatment for low blood pressure?
Well, you know, low blood pressure is, you know, the goal is about 130/80. And when blood pressure gets to be about 100, the higher number gets to be 100 and the lower number gets to be 60. Or the way to know, first of all, let me go back to blood pressure in general. So in order to decide whether you have high blood pressure or not, you really need to take your blood pressure at home with an automatic blood pressure cuff. And I have one right here, all right, because I have high blood pressure. And so in order to make the diagnosis of high blood pressure, your doctor really should not make it on one blood pressure reading in his or her office, because you may be excited. The doctor's wearing a white coat.
Sorry, Fred, you're breaking
You can see
up.
what it is at home to determine whether it's really elevated. It may go back to normal or it may stay elevated. That's number one. But when the way you know when you have low blood pressure, one of the ways besides taking it is to actually when you stand up from either you get out of bed, for example, to urinate in the middle of the night if you're a male like me, or you get up from a chair quickly and you feel lightheaded or you feel dizzy. That may be an indication that, particularly if you're taking a blood pressure medicine, that your blood pressure may be too low when you stand up. And that's called orthostatic hypotension. Hypo means low.
Yes.
And so the way you would know that or suspect that is you felt lightheaded, mainly lightheaded, like you could black out. Some people call that dizzy, but that dizzy means things are spinning. But some people think dizzy means lightheadedness. But the specific kind of dizziness is lightheadedness. When you stand up, you'll get up from a chair or get up from bed to a standing position. That may be an indication that your blood pressure is too low. Is the person who's asking this question on medication, or they're just worried about low blood pressure in general?
That's Marlene. Are you on medication?
No, I'm not. I'm not on medication, and my pressure is normally below 110, but it has been going down recently.
So do you have any symptoms like I described?
Yes, I do.
Okay.
The dizziness, the sort of feeling unsteady.
When you stand up, is it worse when you stand up from a sitting
Yes,
position?
it is. Yes, it is.
Then I think you need to see your doctor to see whether you have what's called orthostatic hypotension. Now, orthostatic hypotension can be caused by a whole bunch of different things, but if you have symptomatic, there's medication we can treat this with. Assuming you're not taking any other medication that could cause this, then it needs to be determined whether your blood pressure does fall. There's other reasons to feel unstable when you stand up from a sitting or lying position as well. So your doctor should see it. But let me tell you something. When you stand up from a sitting or a lying position, do you notice it? Can you prevent the symptom if you get up, if you sit up at the edge of the bed, dangle your feet for a little while, and then stand up and gather your strength?
I'm not sure, but I know I can minimize it if I stand slowly, hold on, and breathe deeply.
Okay.
I've noticed that tends to steady me.
Okay, so certainly that's what I would do to prevent any. Have you fallen at all?
No, I've not.
Have you come close to falling?
Yes, I have.
All right. So I think you need to do two things. One is you need to do what I said in terms of the speed with which you change positions. Are you a fast mover or a slow mover? Or how would
Generally, yes, generally fast. But I'm coming from, especially from a prone position now, I tend to do it more slowly.
So fast movers can run into problems. I'm a fast mover too. And I've tended to become more cautious as I've grown older, recognizing I'm a fast mover. So I go down steps, I hold on to the railing. I go up steps. Most people who fall on steps fall on the way down. And when they fall, they actually fall on the lower part of the steps. So in the beginning, when you start to go down a staircase of steps, your mind is kind of, and your feet are deciding how much you actually have to step down. You're paying attention to that. And then you standardize it on the next few steps. And then toward the end, you get sloppy. You get sloppy and you don't pay attention to how deep the step is when you step down. So that's why, maybe God made it this way. So you don't fall at the top of the steps. You feel thoughtful about how deep the step is. But anyway, you should get up slower, and you need to determine whether you in fact have drops in blood pressure. So your doctor needs to examine you. But you should ask him for orthostatic hypotension. Do you
I
have
will.
Right.
Thank you.
Okay, then there is a comment here. I am not on BP medication for over 10 years. I do craniosacral therapy twice a month now, and it works.
What is it? I don't know what it is.
What is that, Dawn Williams?
I'm not sure how to explain it, but it's a therapy that works on your we have the sacral, you have the I forget what you call it. What the therapist did was work on unblocking my chakras when I started over 10 years ago, and all I know is that it works. Because I do get checked when I go to the doctor for my annual, and my pressure is not my pressure doesn't move at all, but the medication I was on initially was making me sick, and it was just high and wasn't going anywhere. And then I decided to try this therapist with the craniosacral therapy, and it's over 10 years now. It works.
So I think what you said is important. You said you started the medication, you had side effects, and then you decided.
Yes, yeah. The doctors put me on medication when they said I had high blood pressure, and they kept changing the medication, but my pressure remained high.
Mhm.
So something was wrong somewhere. So, and I tried more than one doctor. And then the last doctor I went to, Benton, he just said he doesn't know what's wrong.
I see. So
And then I decided, when I told him about the craniosacral, he says, okay, he had never heard of it. He was dismissive. But he told me to keep in touch because I decided I'm going to stop taking the medication because something is wrong somewhere. Why is my pressure so high? And I mean, I literally was sick.
Yes.
And I went back to him almost a year later. And when he checked my pressure, it was normal.
Okay.
This is after I started craniosacral therapy.
Well, all I can say is that you know, around the world, the majority of people who have high blood pressure actually have been prescribed medication that they're not taking. And either because they have side effects, they can't afford it, or they don't believe it's going to work, or a combination of those things. And they seek other options.
No, well, I went back to the doctors, both doctors that I was going to,
Good.
and they changed the medication, but my pressure was still high.
Right. Did you ever take multiple medications? Different?
Sorry?
Did you ever take 2 or 3 medications, high blood pressure medicines?
When you say take 2 or 3, meaning what?
Meaning 2 different types of pills.
At the same time?
Correct, yes.
I honestly don't remember. That's more than 10 years ago.
Okay. All right, but
I just took the whatever the medication they put me on, I took it as prescribed.
and it didn't work.
It's like it would work for one day and the next day I am sick.
I see. Okay, all right. So
I'm seeing in the chat, Dr. Sherman, I'm seeing in the chat an explanation of what it is, of
good.
right. It's
Okay.
somebody says it sounds like acupressure.
No, I wouldn't say it is, but I know that when I first started, she worked on, well, you know, we speak about chakras.
Yeah.
And she started by unblocking them. So it's an Eastern form of therapy. So no medication. She's not a doctor. The person who does it is not a doctor. She's not a trained nurse. I just know that it works.
All I can say to you is that, and I don't know anything about this therapy, but all I can say to you, if it keeps your blood pressure down, you know, below 130 over 80, in that vicinity.
Well, I don't even have what do you call it, to check my pressure. I don't.
Okay.
My mother used to have one, but I found that.
Well, if it gives you any peace of mind, you may want to buy one. You know, it costs 30 US, and check your blood pressure at home. Make sure it's the same as well.
Well, because I go to her every month, she can tell me if my pressure is a little high or not. She's able to do that. I don't know how, but she's able to do that. And I go to my doctor once a year for my annual.
Sounds good to me.
So I think I am 68. I think I'm doing fine.
I think you are too.
Yeah, because the only medication I'm on now is for my eyes, and well, that's another story.
Okay.
But I take it. I take the medication.
Good.
I'm not seeing too well out of my eyes, but I'm managing.
I see a question here. Well, a comment. I'm 68. Is that you, Joan? Is that Joan who said, no, this is somebody else. Two doctors told me that my BP, cholesterol and early diabetic, I'm on no form of meds, not even painkillers. I take just plain water and rest.
Sounds good.
What do you think, Dr. Sherman?
You know, you have to have some numbers. I mean, I've never met a disease that doesn't have a number associated with it. So I have to know this woman's numbers in order to advise her. But you know, and you know, for example, there are calculators on the web from the American Heart Association and other reputable organizations that you can use based upon your age, your blood pressure, and your cholesterol measurements to predict what your risk is of getting a heart attack or stroke, for example, in the next 7.5 to 10 years. And then based upon that, they give you recommendations of whether you need to lower your cholesterol, you need to lower your blood pressure. So they're available to everybody, and but you need to have some numbers. You need to have your blood
Yes.
pressure, your cholesterol, etc. And you need to know your age and your sex.
Great. Do we have any other questions? Yes, what does it say? I'm not seeing, oh yes, what are the best exercises to assist a wheelchair-bound individual with lower body sarcopenia? The individual is able to stand assisted.
They are able or not able?
They are able to stand unassisted, no, assisted with assistance.
So I think the first thing I would start them, first of all, can they self-propel the wheelchair? For example, many wheelchairs come with leg lifts, so you can get them, all right? If the older adult is sitting in a wheelchair with leg lifts, they can't use their legs to self-propel them, all right? So one thing you could do is to take off the leg lifts and see if the individual can propel themselves with their legs. One of their legs or both of them. With or without their hand. I mean, so you can move a wheelchair in multiple ways. You can move it by turning the wheel, or you can move it by moving your feet. But you need to get rid of the leg chair lift. So there's somebody with a phone.
Is that,
Okay, the individual has a deformed hand. One hand, the left hand is deformed, but if she's assisted, she can stand, but not for very long.
I'm just trying to get her to move in her wheelchair. So if her one arm is paralyzed, she can't use it. Let's just say she can use her right arm. So if she can use her right arm and her left leg, she may be able to self-propel herself with the wheelchair. But that begs the question of what we need to do before she gets to that. I think she needs to get, because you raise sarcopenia, which is muscle mass loss.
Right.
Somebody's in a wheelchair is likely to have lost much more because they live a sedentary, they spend time there. So she needs to start with ankle weights.
Okay.
Increase their quadriceps strength. And in that individual, she may not be able to handle a 5-pound ankle weight. She may have to start at 2 or 3 pounds to start with because she has significant muscle mass loss in the lower extremity. Think of that picture I showed you. Her muscle mass is like the one on top with a little bit of redness and a lot of fat around it. And she needs to build up her muscle mass. And then to see if she can self-propel herself in the wheelchair. And then if she can self-propel herself in the wheelchair, then she can move on to other forms of exercise that may get her standing up. But I don't think walking would be the first.
No.
No pun intended. I don't think walking would be the first step I would take.
No, not at all. Okay, so I can start with at least a half-pound weight to see how increasing.
Usually a half pound. Do 3 sets of 8 repetitions Monday, Wednesday, and Friday. Increase from a half a pound to a pound. Increase from 1.5 pounds, go to 2 pounds. And you may be able to increase it more rapidly than I just described. But the concept is more rapid increase, and give her a rest on alternate days. So it's a Monday, Friday thing. And it's going to take time. This is not something. How old is this woman?
She is 68. She is 68. I'm not hearing you.
sorry, I think you have something on in the background and it's interfering with what we're hearing.
How did she get?
Turn that off, please.
Okay.
Why is she in a wheelchair? Why is she in a wheelchair?
I think she's going to turn off whatever is on because we couldn't hear very well.
Sure.
Yes,
I'm sorry, I had to turn that off.
okay, so he's asking a question.
Please repeat the question.
Why is she in a wheelchair?
She had a hip replacement and it went terribly wrong. She had several infections in the hip and that started it.
Does she have, once again, her ultimate ability to walk, when was her hip operation? How many years ago?
8 years ago.
Okay, and she developed an infection, and did she have the piece of hardware removed from her hip?
No, it is still there.
I see. And is she being treated for a chronic infection there, or that's resolved?
Yes, she is. Yes, she is.
She's on a medication, antibiotic presumably or something.
Right.
Okay, so she has what they think she has chronic osteomyelitis. So I would take, no pun intended, once again, one step at a time here and see, given that how long has she been in the wheelchair now?
She has been in the chair about 6 years.
Yeah. So I would take my time on this. She probably has significant limitation of motion in her hip, infected, so she can't move it like you and I can move our hips. So she needs to go slow, and I would just start with simply increasing the muscle strength in the hip to see if she can do that.
Okay.
I mean, that's a home remedy. I mean, she's a complicated patient.
Yes, she is.
If you can find have you been to see a physical therapist?
Yes, we have done all of that. It's just me now trying to get her refocused. She does a lot of reading. Because of the hand being deformed, she cannot write, but she does a lot of reading. So I tend to give her stretch exercises, and just needed to know what else can I do as it relates to her legs.
Right. I think, first of all, congratulations on what you are doing. It takes a village, it takes a family. You are her daughter, or you are her sister? How are you related?
Well, actually, I am a family friend.
I see. Well, you're doing a very good deed, and you're actually implementing what I call therapeutic advocacy for your friend.
Yeah.
She needs you more than ever. Does she have anybody else besides you?
Yes, she does. She has caregivers that comes around, but because I spend so much time with her and I see sometimes the deficiency in the movements, I tend to have conversation and try to get her to be a little bit more active in terms of movements when I'm around.
Right. So the good news about this is that if what I'm suggesting, I mean, listen, you've taken her back and forth for 6 years to see physical therapists. You see what they are able to do for her. Did they ever give her weights to lift? Did they ever do anything?
She has a 1 pound that she uses for her hand.
Okay.
And it hasn't increased from the pound because sometimes she's unable to grasp. So I understand that.
So I would strap it on the leg, the leg that has not been operated on. Does she, just to be clear, does she have wheelchair lifts, leg lifts on the wheelchair?
Yes, she does.
Has anybody ever taken them off and said, see if you can move yourself?
Well, they can rotate to the sides. So that is why sometimes I will park her in front of a handbar and help her to raise herself to stand, and she will do it.
Okay, I think that what you're doing is actually good for her because it keeps her veins and arteries in her legs reactive to standing. Because if you just sit all day and you don't stand up, then blood may pool in your legs, and when you stand up, you may feel lightheaded and dizzy. So you're doing a good thing there. I would just try to strengthen the muscles in her leg and in the good leg, and see if that helps her self-propel the wheelchair. It's a challenging patient that you have here.
Yes, she is.
And but you are to be congratulated for your persistence and your commitment to her. And also, if the aids that are helping her, if you're successful, and even if you're not successful, you can in terms of getting her to mobilize herself in a wheelchair. And I don't even know if she has the space to go somewhere, even if you do mobilize her. But assuming she does, you can have the aids help you to reinforce the weight training.
Okay, I'll do that.
Congratulations.
Thank you so much.
You're welcome.
Bless you.
Thanks.
So, Dr. Fred Sherman, we are so grateful to you. We know that if we brought down a guest speaker like you to speak to us, it would cost us a pretty penny. And you have volunteered to do this for us. We're very grateful. We're also grateful for the work that you and Pat have been doing with literacy, starting in St. Elizabeth, but moving across the country now. And
Yes.
I just need to mention that the project that they were doing in St. Elizabeth involved the parents of the children. This was before COVID. And because they had been educating the parents to help the children, those children did very well during COVID. So that shows you the results of what you can do when you encourage parents to participate. And please look up LIFE, L-I-F-E, literacy is a family experience on the web to learn more about Dr. Fred and Pat Rose activities for education. And we thank you so much, Doc, and we hope that when you next come to Jamaica,
We're coming soon. We're coming soon.
when
We're
you next
gonna
come,
see you, Jane. We're gonna see
yeah,
you.
right, we're not going to make you work, but if we have a social event, like a games evening, we'd love to have you and your wife join us so that we can all meet you in person.
Thank you very much. It's been my pleasure.
Thank you. And thank you all for attending and asking great questions. I think we really learned a lot. This is being recorded and we will be sharing it with our membership. Thank you, Dr. Sherman, and please give our regards to your dear wife.
I
Thank you.
will. Thank
Have a
you.
good evening.
Be
Bye.
well.
now.
Yes.
Thank you.